Hey everyone, my name is Saad Zatari. I'm a third-year emergency medicine resident at the Georgetown University Hospital in Washington, D.C. Today I'll be talking to you briefly about age-adjusted D-dimer levels and their use in predicting for PE in patients with COVID-19. Listed here are my co-authors. I do not have any financial conflicts of interest to disclose. Let's start with the background and objectives. COVID-19 has been well studied in the last year. We know that COVID-19 is associated with a hypercoagulable state and that patients that end up developing pulmonary embolism tend to do worse. In practice, we can't screen all our patients with the use of advanced imaging. And so in practice, using D-dimer as a biomarker would be extremely helpful to guide our decisions on starting empiric anticoagulation. Our study was designed to contribute to the existing knowledge base in this field, and specifically using D-dimers among patients with COVID-19, as well as to try to identify a specific cutoff level that would consistently be associated with venous thromboembolism in this patient population. The methods: this was a retrospective chart review across 7 local hospitals within our system in the Mid-Atlantic area. Patients were considered eligible for inclusion if they tested positive for COVID-19, were then hospitalized and underwent D-dimer testing with subsequent CTPE. Here you can see to the right, we have initial total sample size of 246, and then some of the CTPE studies were inadequate, so those were excluded. A few other patients did not have a D-dimer measured, which ultimately leads us to 150 patients that were included that did have a D-dimer measured. Within that population, we had 16% positivity for PE, and the analysis of these 150 patients were not all that surprising. We found that D-dimer levels are useful in the same way that they would be useful for the general population. It's a sensitive marker for PE. So we found that the age-adjusted D-dimer cutoffs were 100% sensitive for PE among patients with COVID-19. We were unable to show or reproduce the findings from other studies where very high D-dimer levels, such as over 20 milligrams per deciliter, was not consistently pointing us in the direction of a pulmonary embolism. Here we see on this graph here is a ROC curve modeling for the optimal empiric cutoff for D-dimer levels. And what we're trying to demonstrate here is this green line would be a coin toss in terms of a test that is not helping us at all. A perfect test would be something that would go along this line, and we're somewhere in between with our D-dimer levels and screening for PE. So it's overall an okay test, but by no means perfect, and has its limitations. So our conclusion based on our study here was that age-adjusted D-dimers can be safely used for COVID-19 patients in the same way that we use them for the general population, i.e. it's a sensitive test that we can kind of feel reassured that if it's negative, that it's unlikely that that patient will have a PE. However, we did not find a cutoff level that would consistently 100% of the time show that a PE was present. So our final conclusion was we recommend against relying solely on D-dimer levels to guide anticoagulation, and we're looking forward to the rest of the literature in this field. Thank you.